Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 309 of our pharmacotherapy series, which majors in cardiac arrhythmias. The first question reads, MPC is a 38-year-old woman who has had frequent episodes of atrial flutter for the past 2 years. She has no other medical history and is taking metoprolol 50 mg twice daily. She does not want to take the drug any longer because it reduces her exercise tolerance. Does the treatment of atrial flutter differ from the treatment of atrial fibrillation, and what is the role of radiofrequency catheter ablation for MPC? Atrial flutter is an unstable rhythm that often reverts to sinus rhythm or progresses to atrial fibrillation. If atrial flutter is episodic, its underlying cause should be identified and treated if possible. If a patient remains in atrial flutter, the treatment goals, that is control of ventricular rate, and return to normal sinus rhythm, are the same as those for atrial fibrillation. Similar agents and doses can be used to control the ventricular response. Chemical conversion, low energy, less than 50 joules, direct current cardioversion, or rapid atrial pacing may acutely convert atrial flutter back to sinus rhythm, but the recurrence of atrial flutter is high. Radiofrequency catheter ablation therapy could be used as a non-pharmacologic treatment for atrial flutter and atrial fibrillation. With both atrial flutter and atrial fibrillation, an electrophysiological study is performed to identify whether ablation can be performed. Various sections of the atria and pulmonary veins, where they intersect with the atria, are probed with a catheter that delivers cardiac pacing. If an area is stimulated with pacing and an atrial ectopic or reentrant focus is recognized, that area could be ablated. Ablation destroys tissue that is integral either to the initiation or to the maintenance of the arrhythmia by delivering electrical energy through electrodes on the catheter. If the focus of the arrhythmia is in the atrial tissue, typically for atrial flutter, then the focus itself is ablated. This procedure is successful in 75% to 90% of cases and can be recommended for patients with atrial flutter who are drug-resistant or drug-intolerant, or do not desire long-term therapy. In atrial fibrillation, an ectopic focus originating in the pulmonary veins can often initiate the arrhythmia. In this case, circumferential ablation, in which a circle of ablated tissue is made around the pulmonary veins, is performed. Circumferential ablation does not prevent the ectopic impulses from the pulmonary veins from occurring, however, it does prevent propagation of the impulse into the atria and may reduce the recurrence of atrial fibrillation. Recent data comparing ablation to antiarrhythmic drug therapy in patients with paroxysmal atrial fibrillation suggest that ablation is more effective in preventing recurrence of atrial fibrillation than medications. Radiofrequency ablation therapy may be suitable for MPC, however, if exercise intolerance is her primary complaint, this might be relieved by switching MPC to another drug, such as verapamil. The next question reads, BJP, a 32-year-old woman, presents to the emergency department complaining of fatigue and palpitations. She has had similar episodes approximately twice a year for the past 2 years, but has not sought medical attention for them. She is in no apparent distress and has a temperature of 98.0 degrees Fahrenheit, heart rate of 185 beats per minute, BP of 95 systolic 60 diastolic, and respiratory rate of 12 breaths per minute. Her ECG shows regular rhythm with a heart rate of 185 beats per minute. The P waves cannot be found, and the QRS complex is 110 milliseconds. The normal value is 120 milliseconds. She has no past medical history of note. What is the clinical presentation of paroxysmal supraventricular tachycardia, and what are the consequences of this arrhythmia? Paroxysmal supraventricular tachycardia often has a sudden onset and termination. At the time of paroxysmal supraventricular tachycardia, the heart rate is usually 180 to 200 beats per minute. As illustrated by BJP, patients experience palpitations and often nervousness and anxiety. In patients with a rapid ventricular rate, dizziness, and syncope can occur, and the rhythm may degenerate to other serious arrhythmias. Angina, heart failure, or shock may be precipitated by underlying severe atherosclerosis or left ventricular dysfunction, but this is not part of BJP's past medical history. There is no evidence that patients with episodes of paroxysmal supraventricular tachycardia are at an increased risk of stroke. The next question reads, what is the arrhythmogenic mechanism of paroxysmal supraventricular tachycardia? AV nodal reentry is the most common mechanism of paroxysmal supraventricular arrhythmias. Here AV nodal impulses are blocked in one of two directions in an antegrade fashion, but when reaching the end, conducts in a retrograde fashion, setting up a circular reentrant circuit. Reciprocating tachycardias occur when there is an accessory pathway for conduction of impulses between the atria and ventricles, like with Wolff-Parkinson-White syndrome, and paroxysmal supraventricular tachycardia results. The next question reads, BJP tries the Valsalva maneuver, and her ventricular rate is reduced to 150 beats per minute, the other parameters are unchanged. She is given IV adenosine 6 mg, administered over 1 minute with no effect on the paroxysmal supraventricular tachycardia rate. Another dose of adenosine 12 mg given over 1 minute has no effect. No side effects are noted from therapy. What treatment options can be used if BJP is hemodynamically unstable? What is the Valsalva maneuver? What is the probable reason for BJP's unresponsiveness to adenosine? Are there any drug interactions that might diminish adenosine's effect? Let's look at non-drug treatment. We will begin with the Valsalva maneuver. Although her BP is low at 95 systolic 60 diastolic, BJP is maintaining an adequate perfusion pressure, so vagal maneuvers should be attempted first. Two common vagal techniques are pressure over the bifurcation of the internal and external carotid arteries and the Valsalva maneuver, forcible exhalation against a closed glottis, similar to bearing down to have a bowel movement. The increase in pressure induced by these maneuvers is sensed by the baroreceptors, causing a reflex decrease in sympathetic tone and an increase in vagal tone. The increase in vagal tone will terminate in 10% to 30% of cases. If BJP was hemodynamically unstable or becomes hemodynamically unstable, she should receive synchronized direct current cardioversion. Let's look at drug therapy. We will focus on adenosine. Because most paroxysmal supraventricular tachycardia episodes involve re-entry in the AV node, drugs that block the AV node, also known as negative dromotropic drugs, are generally effective. Adenosine, a purine nucleoside that exerts a transient negative chronotropic and dromotropic effect on cardiac pacemaker tissue, is considered the drug of choice for the acute treatment of paroxysmal supraventricular tachycardia because of its rapid and brief effect. An initial 6 mg IV bolus is given. If this is unsuccessful within 2 minutes, it can be followed by 1 or 2 12 mg IV boluses, up to a maximum of 30 mg. Because of its short half-life, that is 9 seconds, adenosine should be administered as a rapid bolus, over 1 to 3 seconds, followed immediately by a saline flush. Adenosine begins to be metabolized immediately after entering the bloodstream, therefore, BJP's failure to respond is likely attributed to the prolonged, that is 1 minute, infusion time. Theoretically, adenosine may be ineffective or higher doses may be required in patients who are receiving theophylline because theophylline is an effective adenosine receptor blocker. Larger doses of other methylxanthines, from caffeine, or guarana, may also theoretically interact like theophylline. Conversely, concomitant use of dipyridamole may accentuate adenosine's effects because dipyridamole blocks the adenosine uptake, and subsequent clearance. The next question reads, BJP is given 12 mg adenosine IV during 2 seconds, followed by a 20 ml normal saline flush. 30 seconds later, she complains of chest tightness and pressure. What is the explanation for these symptoms? BJP is experiencing a common side effect of adenosine. Patients receiving adenosine should be warned that they may feel transient chest heaviness, flushing, or a feeling of anxiety. Shortness of breath and wheezing may be observed in patients with asthma. The denervated heart of the patient who has undergone heart transplant is particularly sensitive to adenosine, therefore, lower doses of adenosine should be used. The next question reads, BJP is still in paroxysmal supraventricular tachycardia. What other acute therapeutic options should be considered at this time? Non-dihydropyridine calcium channel blockers, verapamil, and diltiazem, can be used in patients with paroxysmal supraventricular tachycardia. Verapamil, 5 to 10 mg or 0.075 to 0.15 mg per kilogram IV given over 2 minutes, achieves peak therapeutic effects in 3 to 5 minutes after dosing and can be repeated at 10 to 15 minute intervals to a maximal dose of 20 mg if needed. The elderly should receive the verapamil infusion over 3 minutes to minimize the risk of adverse events. Diltiazem is given as a 0.25 mg per kilogram IV bolus over 2 minutes, and a second bolus of 0.35 mg per kilogram can be given 15 minutes later if the effect is inadequate. Both of these calcium channel blockers have an 85% conversion rate. However, verapamil should not be used in patients with wide complex tachycardia of unknown origin because it may lead to hemodynamic compromise and potentially ventricular fibrillation. Beta blockers and digoxin can be used if calcium channel blockers and adenosine fail. The next question reads, BJP is given 5 mg IV verapamil, followed by an additional 5 mg 10 minutes later. She converts to normal sinus rhythm 3 minutes after the second dose. Because she has experienced symptoms that could be attributed to paroxysmal supraventricular tachycardia in the past, she may be a candidate for chronic therapy to slow conduction and increase refractoriness at the AV node. Which agents have been evaluated for this indication? Is there a role for radiofrequency catheter ablation therapy for paroxysmal supraventricular tachycardia? Radiofrequency catheter ablation is frequently used as a definitive treatment for paroxysmal supraventricular tachycardia. Electrophysiological testing is used to determine the location of the reentrant tract, which then can be ablated, thereby interrupting accessory pathways and reentrant circuits. This treatment approach is potentially curative and is performed by an electrophysiologist. Patients who are not candidates for ablation, or who do not wish to undergo the procedure, can receive medications on a chronic basis. Paroxysmal supraventricular tachycardia managed with agents that slow conduction and increase refractoriness in the AV node, thereby preventing a rapid ventricular response. These include oral verapamil, diltiazem, beta blockers, or digoxin. Class 1C and 3 agents are used occasionally to slow conduction and increase refractoriness of the fast bypass tract to prevent triggering impulses such as premature atrial and ventricular contractions. BJP has had a few episodes of paroxysmal supraventricular tachycardia in the past and may be a candidate for ablation. Alternatively, because she responded to IV verapamil, oral SR verapamil could be prescribed at a dosage of 240 mg per day. The next question reads, MBC, a 35-year-old man, presents to the emergency department with a chief complaint of chest palpitations for 4 hours with intermittent feeling of almost passing out pre-syncope. MBC's vital signs are BP of 96 systolic 68 diastolic. A pulse of 226 beats per minute, irregular respiratory rate, 15 breaths per minute, and temperature, 98.7 degrees Fahrenheit. A rhythm strip confirms atrial fibrillation, with a QRS width varying from 0.08 to 0.14 seconds. To control the ventricular rate, 10 mg IV verapamil is administered over 2 minutes. Within 2 minutes of completing the infusion, ventricular fibrillation is noted on the monitor. MBC is defibrillated, and normal sinus rhythm is restored. A subsequent ECG demonstrates a PR interval of 100 milliseconds. The normal range is 120 to 200 milliseconds, and delta waves, compatible with Wolff-Parkinson-White. He relates a past medical history of many similar self-terminating episodes since he was a teenager, but he has no atherosclerotic heart disease or heart failure. He took an unknown medication 5 years ago that decreased the occurrence of the palpitations, but he stopped taking it because of side effects. What is Wolff-Parkinson-White syndrome? Wolff-Parkinson-White is a pre-excitation syndrome in which there is an accessory bypass tract connecting the atria to the ventricles. An impulse can travel down this pathway and excite the ventricle before the expected regular impulse through the AV node arrives. If there is antegrade conduction over the bypass tract while the patient is in normal sinus rhythm, the ECG will demonstrate a short PR interval that is less than 100 milliseconds, a delta wave that represents a fused complex from pre-excitation, and the regular QRS complex after AV conduction. Paroxysmal supraventricular tachycardia and atrial fibrillation occur in these patients at a higher incidence than in the general population of the same age. Similar to MBC, the rapid heart rate experienced during the tachycardia may cause palpitations, lightheadedness, and fatigue. When patients with Wolff-Parkinson-White develop atrial fibrillation, there is a danger that the rapid atrial impulses will be conducted directly to the ventricle through the bypass tract, causing a rapid ventricular rate that may evolve into ventricular fibrillation. Verapamil, like diltiazem, beta blockers, adenosine, and amiodarone, can increase this risk by increasing the effective refractory period of the AV node and indirectly reducing the effective refractory period in the bypass tract. The next question reads, why did verapamil cause ventricular fibrillation in MBC? What therapies would be appropriate for MBC, and what drugs should be avoided? Because MBC had atrial fibrillation, the rapid atrial impulses were conducted directly down the bypass tract to the ventricle, causing ventricular fibrillation. The antiarrhythmic drugs used to chemically convert patients with atrial fibrillation who have Wolff-Parkinson-White, such as MBC, include procainamide, propafenone, flecainide, and dofetilide. Direct current cardioversion is an option for more emergent conversion of atrial fibrillation in patients with Wolff-Parkinson-White and hemodynamic instability. Radiofrequency ablation of the bypass tract is curative for many patients with Wolff-Parkinson-White and is indicated for people who maintain pre-excitation during exercise stress testing, a shortest pre-excited RR interval less than 250 milliseconds, symptoms like syncope of palpitations, or pre-existing structural heart disease. MBC has symptoms associated with atrial fibrillation in Wolff-Parkinson-White and should undergo evaluation from an cardiologist to determine if ablation is appropriate at this time. Further therapy for MBC may not be useful at this time. However, if he has recurrent atrial fibrillation or other symptomatology associated with Wolff-Parkinson-White, radiofrequency catheter ablation could be indicated. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 310.